Hello everybody. Today we'll be discussing the evaluation of a patient with foot drop, specifically differentiating between lumbar radiculopathy and peroneal nerve palsy. Just to briefly outline the presentation, we'll first discuss some epidemiology, followed by a history and physical. We'll then get into the diagnosis and conclusions, as well as show an accompanying video demonstrating the diagnosis. So as for the epidemiology, foot drop is characterized by a weak anterior tibialis muscle on dorsiflexion, and foot drop most commonly arises from pathology in the L4-5 region. There's also a group of neuropathies known as a hereditary motor sensory neuropathy, HMSN to be abbreviated, which are an inherited group of peripheral nerve disorders associated with decreased production of proteins within or myelination of the peripheral nerves, and HMSN can also present with foot drop. One specific type of HMSN is Charcot-Marie tooth disease, or CMT. It's the most commonly inherited HMSN, and has a prevalence of around 40 per 100,000. Slightly over 1/3, at around 36% of patients with CMT present with peripheral nerve palsy with a foot drop. So the purpose of this slide set is to go over in a diagnosis of foot drop how one can differentiate between foot drop, which is secondary to stenosis at the L4-L5 region, from peroneal nerve palsy such as Charcot-Marie tooth. So in this case, a patient presented with loss of dorsiflexion of the left foot, so foot drop, as well as loss of arches on the left foot. The patient was able to invert the left foot, but was unable to evert that same foot. Of note, the patient also had normal sensation along the dorsum of the left foot, as well as intact gluteal muscles as well. So when it comes to differentiating between L4-5 radiculopathy and peroneal nerve palsy, a couple of things can be tested. One is the ability to invert and evert the foot, as discussed above. Two is the sensation along the anterior portion of the foot, as well as the involvement of the gluteus muscles and the tensor fascia lata. So this patient's ability to invert but not evert the foot, coupled with normal sensation along the anterior portion of the foot, as well as intact gluteal muscles in the TFL, indicated a deep peroneal nerve palsy rather than an L4-5 stenosis. So now we'll just show a quick video accompanying this diagnosis.
Hi, how are you? Today we're going to look at a patient who comes in with a foot drop, and we're going to go through some of the ways to differentiate and look at that. So this gentleman has had a foot drop, and the first thing when you look at his foot, you can see he has Charcot changes to his foot, where he's sort of lost all his arches and his foot. So we ask him to bring up his toes to his head. Go ahead, sir. And you'll notice he has no strength in his anterior tibialis. So the first thing we have to do is differentiate, is this a L5 or L4 nerve problem, or is this a peroneal nerve problem? So the way to do that is, first, can you invert your foot this way, towards me? And he's got excellent inversion. Next is you go, can you evert it, or push your foot out? And he has zero strength there. And so when we put it together, we go, excellent inversion, no eversion, no anterior tibialis. You have any sensation here? Is this normal? He has normal sensation. That goes together, that's a peroneal nerve palsy, not an L5 radiculopathy. Thank you.
So that video concludes the slide set, and in the following slide I'll just show some brief references, and thank you for your time.